You might think you know everything there is to know about keeping your bones strong and your heart healthy. You probably even take supplements, dutifully following advice that's been around for decades. But what if I told you that one of the very things you're doing to protect yourself might actually be putting your life at risk? What if the key to truly understanding arterial blockages and bone health has been a hidden secret, a vital piece of the puzzle that most people have never even heard of? Today, we're diving deep into a topic that could fundamentally change your approach to health, revealing a profound connection between calcium, your arteries, your bones, and a largely forgotten nutrient that holds the power to redirect calcium where it belongs. Get ready to uncover a truth that health authorities have only recently begun to fully grasp, and learn why ignoring it could have serious, life-threatening consequences. For years, as a medical professional, a striking pattern emerged in the patients I observed. Those suffering from heart disease and arterial blockages often presented with a cluster of related conditions. It wasn't just diabetes or high blood pressure. These individuals frequently battled degenerative joint disease, severe arthritis, obesity, and surprisingly, poor dental health, including rampant decay and gum issues. This persistent co-occurrence, particularly the link between coronary artery disease and debilitating conditions like osteoporosis, where patients required hip and knee replacements, always piqued my curiosity. It begged the question, what underlying factor could connect heart ailments with compromised bone health? This enduring mystery led me to embark on a quest for answers, specifically focusing on calcium. My research into calcium quickly revealed a concerning trend. Due to pervasive issues like osteopenia and osteoporosis, many patients were routinely prescribed calcium supplements. However, alarming studies began to surface, indicating that the very calcium supplements intended to bolster bone health and promote overall well-being were, paradoxically, linked to an increased risk of mortality. Multiple studies have now demonstrated that consuming more than 1 gram of calcium supplementation daily can elevate cardiovascular risk by a significant 20%. This finding is particularly striking when you consider that if a drug could reduce cardiovascular risk by 20%, it would be hailed as a medical breakthrough. Yet, the opposite, the increased risk associated with calcium supplements, often goes unmentioned. This revelation ignited my interest, compelling me to investigate why calcium, a seemingly essential nutrient, could pose such a danger. Further examination, notably through extensive research like the Women's Health Initiative study, corroborated these findings, showing that even elemental calcium supplementation of 1 gram daily could increase overall mortality by 15 to 22%, irrespective of whether vitamin D was also taken. This heightened risk was similarly observed in renal failure patients who were routinely given calcium supplements, seeing their risk climb by 22%. It became clear that while these patients were taking calcium with the intention of building strong bones, teeth, and joints, the outcome was often far from beneficial. The question then became, what is it about calcium supplementation that leads to these detrimental effects? Initial theories posited that it might increase clotting, as calcium is known to facilitate blood coagulation. Another thought was a potential link to high blood pressure, given that elevated calcium levels can be associated with hypertension, though this wasn't consistently observed in supplement users. The precise mechanism remained elusive, prompting a critical reevaluation of current practices. Therefore, my emphatic recommendation to everyone is to avoid taking calcium supplements unless explicitly advised by a physician, as the readily available over-the-counter options may carry unforeseen risks. The deeper understanding of calcium metabolism reveals a crucial missing piece in the puzzle: vitamin K2. This fat-soluble vitamin, often unheard of by many, is absolutely essential for proper calcium utilization within the body. Its fat-soluble nature means it requires dietary fats for effective absorption. In essence, vitamin K2 is indispensable for robust bone metabolism. Without sufficient K2, the body struggles to maintain bone integrity, leading to conditions like bone disease. So, why are so many people deficient in this vital nutrient? The answer lies largely in the dramatic shifts in modern lifestyle and dietary habits. For the past 4 decades, the widespread adoption of low-fat diets, a dietary experiment whose pitfalls have become increasingly apparent, has inadvertently led to deficiencies not just in vitamin K2, but also in other crucial fat-soluble vitamins like A, D, and E. These vitamins, even in small amounts, exert powerful effects on the body, and their absence due to restrictive low-fat eating can have profound consequences. The intricate dance of bone formation and breakdown within our bodies relies on two primary cell types: osteoblasts, which are responsible for building bone by incorporating calcium from the bloodstream, and osteoclasts, which demineralize bone by releasing calcium back into circulation. For osteoblasts to effectively bind calcium and build strong bones, a protein called osteocalcin must be activated, and this activation is utterly dependent on vitamin K2. Without K2, osteocalcin cannot undergo the necessary carboxylation, rendering it unable to bind calcium effectively. Similarly, in other tissues throughout the body, a counterpart protein known as matrix GLA protein, MGP, also requires activation by both vitamin D and, critically, vitamin K2. Unlike osteocalcin in bones, MGP in tissues plays a different role. It binds calcium and actively removes it from soft tissues, such as blood vessel walls, ensuring it circulates towards the bones. These matrix GLA proteins are predominantly produced by the smooth muscle cells lining our blood vessels, the very cells responsible for regulating blood vessel dilation and constriction. When vitamin K2 is present and active, it enables MGP to bind excess calcium within the blood vessels, preventing its dangerous accumulation and moving it back into the bloodstream to be directed towards bone tissue. Conversely, in the absence of vitamin K2, this protective mechanism falters. Calcium remains in the blood vessels, leading to calcification of arterial walls, while bones become demineralized because the essential protein, osteocalcin, that traps calcium in the bone cannot function. This explains the widespread phenomenon we observe: increased degenerative joint disease, widespread osteopenia, and rampant calcification in places it absolutely shouldn't be, like our arteries, which become stiff and ossified. The body's total calcium may be adequate, but without K2, it's tragically misplaced, ending up in arteries instead of bones. Calcium supplementation alone cannot rectify this imbalance because it lacks the necessary cofactors and enzymes, like activated vitamin K2, to correctly deposit calcium. The intricate world of vitamin K encompasses multiple forms, but the most significant for human health are K1 and K2. Vitamin K1, primarily found in green leafy vegetables, is crucial for blood coagulation, a function so prominent that it historically overshadowed K2's equally vital roles. Indeed, the very existence of K2 and its distinct functions were missed for decades because all types of vitamin K were broadly grouped together. Interestingly, there are up to 10 known types of vitamin K, but K1 and K2 are the most impactful. The anticoagulant drug Coumadin, for instance, works by antagonizing vitamin K1, thereby preventing blood clots. However, a critical consequence of Coumadin use is that it also antagonizes vitamin K2. This means that patients on long-term blood thinners are inadvertently inducing a vitamin K2 deficiency. For over 30 years, it has been observed that Coumadin users frequently suffer from widespread arterial calcification, affecting the aorta, heart valves, and coronary arteries. This historical clinical observation, now corroborated by scientific understanding, reveals that Coumadin patients not only have suppressed K1, which is intended to prevent clotting, but also a detrimental deficiency in K2, leading to the deposition of calcium in soft tissues where it does not belong. So, while vitamin K1 is abundant in green leafy vegetables, marine algae, and other chloroplast-rich sources, where does vitamin K2 originate? There are two primary sources: animal products and, perhaps surprisingly, fermented foods. Vitamin K2 exists in various subtypes, with MK4 found in animal sources and MK7 predominantly in fermented products. MK7 is a longer, more biologically active molecule. Historically, foods like meat, eggs, and dairy were excellent sources of K2. However, the quality of these animal products has declined significantly. Animals raised in conventional farming systems, fed grains rather than their natural diets of green grasses and forage, produce meat and eggs with substantially lower K2 content. True vitamin K2 must come from nature's original sources through animals consuming K1-rich plants or through the fermentation process. Fermented foods, my personal favorite, are remarkable for their ability to generate significant amounts of K2. When adequate vitamin K2 is absorbed, it activates matrix GLA proteins, leading to strong bones and the crucial inhibition of calcification in blood vessels. Despite its profound importance, direct measurement of vitamin K2 levels in the body remains challenging, as no widely available clinical test exists. Instead, researchers rely on measuring non-carboxylated proteins, which serve as indicators of K2 deficiency and are currently confined to research settings. Using these methods, a strong direct correlation has been established between elevated levels of non-carboxylated matrix GLA proteins indicating K2 deficiency and the extent of arterial calcification. This compelling evidence underscores the widespread nature of the problem. Further validation came from the landmark Rotterdam study, which followed thousands of men and women over 55 for 8 years. This study meticulously documented dietary vitamin K2 intake and found a powerful correlation. Higher vitamin K2 intake was directly linked to reduced aortic calcification, less coronary artery disease, and remarkably lower all-cause mortality. Specifically, consuming more than 32 micrograms of vitamin K2 per day was associated with an astonishing 50% reduction in cardiovascular death and a 25% decrease in all-cause mortality, capturing the attention of cardiologists worldwide. This suggests that K2's protective effects extend beyond just heart health, potentially influencing other critical areas, including a reduced risk of certain cancers, a topic that continues to be explored.